জি স্যার।
কামরুল ভাই,
আদাব স্যার।
আদাব।
সজল স্যার।
হ্যাঁ আদাব। জামিল ভালো
আছি আলহামদুলিল্লাহ, আপনি কেমন আছেন স্যার?
আছি মোটামুটি।
কামরুল ভাই, আমরা কি শুরু করতে পারবো?
কত বাজে দাও? হ্যাঁ
তুষার ভাই এই যে 10 সেকেন্ড 10 সেকেন্ড
হ্যাঁ, আপনি শুরু করেন, 9:40
10
বাজে।
সেকেন্ড পরে। হ্যাঁ ঠিক আছে।
Assalamu alaikum and good evening, respected physicians. Today we have another exciting session organized by ECG Study Group, ECG Basic and Beyond. And today our speaker is none other than Professor Rafique Ahmed sir. As usual, before the start of the lecture, I'd like to request Professor Abdul Chowdhury sir to introduce Rafique Ahmed sir again in a brief, and then we start the lecture. Wadud sir.
Assalamu alaikum everybody and good evening. Today we're going to have again basic lecture about AV conduction. Now that will be delivered by Professor Rafique Ahmed. Rafique sir is what I should say in Bangla is our guru. And the beauty of his lecture is that when he means basic, he means basic. And he has the ability to make the basic very palatable and very, I should say, student-friendly, listener-friendly. Things become much cleaner and very easily understandable from his lecture. So, ladies and gentlemen, let's enjoy the show. This is Dr. Rafique Ahmed from USA.
Yes. শোনা যাচ্ছে কথা?
জি স্যার।
Yeah, thank you for this topic was given to me by Tushar, and it's a simple and also difficult topic a little bit. But I want the lecture, most of the contents are simple. You all know it, so I thought maybe I'll give a little different perspective of this. So AV conduction, basically, if we look at the heart, we have sinus node, and then we have the AV node, his bundle, right bundle, and left bundle. And that's how the electricity conducts. And if I give it a better picture, so you can see the AV node up here, sinus node up here. Sinus node is actually a long structure. It's about 1 inch long. So it's very difficult to destroy sinus node. That's why when we have infarct or other things, we don't do much damage to it. AV node, even though it's done as a round structure, it's a little bit more complex. It has a lot of trabeculae around here. It's not really round as it is depicted in this picture. And then we have the his bundle and the right bundle, and the left bundle goes, the right bundle comes on the surface. And that's why when we put catheter, we can easily damage it. And it's a small structure. We can traumatize it, and we can develop right bundle bunch block. When we do catheterization, we see it quite frequently that we put a catheter in the right side, so then the patient develops right bundle. That's because of transient trauma. And then the left side goes, and the left side is actually much broader structure. It goes and then spreads out left anterior fascicle and right. And then it's branches and then Purkinje fibers. So and that's the conduction system. So we can develop AV block if we have block in any of the structures. Like we can have block in the AV node, proximal part of the AV node, distal part, his bundle. If we have complete block at the right and left bundle, that would produce complete heart block. And so that can be. Now the heart. So this is the ECG. We can see P wave, QRS complex, and then QT interval, basic structure. And which part? I look at this picture. If you look at the P wave is atrial activation. However, AV conduction starts pretty soon as the P wave is progressing, because remember, P wave is the activation of both right and the left atrium. By the time the electricity reaches the AV node, left side is still activating. So that's why AV conduction starts here. And the traditional PR interval that we see, that's partly AV conduction, part conduction through the His bundle, and then part conduction through the bundle branches, Purkinje fibers, and then when it reaches the myocardium, that's when we see the QRS complex. So the PR interval is actually conduction, AV node, His bundle, bundle branch, and then part of the Purkinje fiber, and then distally we see the QRS complex. If I put a catheter in the AV node area, and this is not for the electrophysiology, but for general fellows, please remember, this is a very simplified picture. I'm making up this story that there is conduction through the AV node, His bundle, bundle branch. Is it true? Can we prove it? Yes, I can put a catheter near the AV node, and you can see there are 4 poles in here, and I can record signals. And if I record signal, I can record the atrial activation and then His activation. So that means this is the time needed by the electricity to go through the AV node, and exactly how it is depicted here. How about here? You can see there is nothing before. I did not show a catheter in the high right atrium. So this is the time needed by the electricity go from here to the AV node. So that's the time. And then, of course, you see there is still some PR interval left here. And that's the bundle branch block conduction and the Purkinje fiber conduction. And then we start the QRS complex. What happens? What modifies this conduction? And we have autonomic nervous system influence. An autonomic nervous system that is predominantly innervates the AV node, His bundle region, and also the right atrium. And it has been clearly proven that the cholinergic nerves, which is the vagus nerve, and the adrenergic fibers supply the AV node, His bundle region more than ventricle. And contrary to popular belief, His bundle conduction is not affected by the sympathetic stimulation or the vagal stimulation. What does it mean? So how does vagus nerve work? Vagus nerve actually is a cholinergic nerve, but it actually works through adrenergic tone. Vagal stimulation will allow release of norepinephrine. And also it can affect the channels by inhibiting cyclic CMP. And there is differential effect. This is interesting that if you stimulate the right carotid sinus, you will see predominantly sinus slowing because right vagus nerve affects the sinus node more than the AV node. If we do left carotid sinus stimulation massage, you'll see more AV block because it affects predominantly the AV node than the other structures. Sympathetic vagus nerve has minimal effect on the ventricle. It's not that there is no effect, but it's minimal. Sympathetic nerve effect is significant. An interesting part is that just like the vagus nerve, there is lateralization. So if left stellate ganglion is stimulated, it affects the lateral side of the left ventricle. Right stellate ganglion affects the right. And these are kind of interesting concepts. And these concepts are coming into play because there are stimulators being developed with this concept. Whether they work or not, that's a different story. But these, to modulate these sympathetic tones and the vagal tone, will it have any effect on the heart? There are studies going on. And also for us, for AV block, it's important to know, because am I going to give an atropine to a patient? Am I going to give some kind of sympathomimetic agent to a patient who comes with bradycardia? We need to make the decision. AV block, what are the types? There's first degree AV block, second degree. We call it type 1, which is Boenkeba. It's confusing to remember all these names, but type 2. So remember type 1 and type 2, and type 2 sometimes they'll call Morbis type 2, and this type 1 is typical Morbis. But I think out of respect to these two individuals, they have decided to split it up. And then third degree AV block. And the question always comes, high grade AV block. What is high grade AV block? So by conventional definition is that if 2 or more non-conductive P wave is present in a tracing, and then followed by resumption of conduction, we will define it as a high-grade AV block. and third degree as opposed to third degree, that it will stay in this complete heart block status. So this is, I mean, this term we used it colloquially. Now it's even in the books, they mention this high-grade AV block. Etiology, congenital AV block. And by the book, the definition should be that it must be diagnosed in utero or in the first month of life. Of course, I mean, this is quite good for developed countries, but in Bangladesh, nobody records ECG when the child is born or intrauterine EKG, so we can't diagnose those. And acquired AV block, most of the time that we see progression of conduction system disease, and we don't know why it happens, but it happens. Then ischemic heart disease is important and also depends on which vessel is affected. So if somebody has right-sided infarct, which affects the right coronary artery, you can have transient first degree, second degree, or third degree AV block. The good thing about right-sided right coronary artery disease is that if you open the artery within 24 to 48 hours, majority of the conduction comes back. And I have waited up to 7 days. So if somebody presents with inferior myocardial infarction, complete heart block, or second degree AV block, when we have done stenting of the vessel, we will wait and see if the conduction comes back. And before the patient goes home, we may want to do a low-level exercise test to see what the conduction is like. And if conduction looks good, patient goes home. We don't necessarily put a temporary pacemaker in these patients. Of course, during intervention, Hafiz may choose to put a temporary wire, but once he does open the vessel and he sees the conduction is back, he may remove the temporary catheter. We take the temporary transvenous catheters lightly, but there are issues with it. Then we have inflammatory and infectious disease. Sarcoidosis is a cause. Granulomatous disease. In America, we have Lyme disease, which is a very common in certain parts of the United States, especially the area that we live. And if anybody young comes in with heart block, when I say young means below 60, and they have any history of outdoor activities, including deer hunting, we always do Lyme test before you put a pacemaker. In South America, Chagas disease is an important cause of heart block. So people travel a lot these days. And if you find a South American person with heart block, make sure that we rule out those things. Tuberculosis can cause disease. It is rare. And then infiltrative disease, amyloidosis, can be a cause. Iatrogenic, the commonest cause now is actually TAVR. So if we do TAVR, about 10 to 14% of patients develop heart block, and they end up needing pacemaker. Of course, alcohol septal ablation for hypertrophic cardiomyopathy, post-cardiac surgery, especially aortic valve replacement. The reason it happens is that when they switch at the aortic valve, they can damage the conduction. So it's very close where the fibrous membrane is. Drugs. The question of drug is important. We find patients with beta blocker that develops heart block. Beta blockers don't cause heart block. It may unmask patients with propensity for heart block. To produce heart block with beta blocker or calcium channel blocker, you will have to give so much medicine that you will make them markedly bradycardic, sinus bradycardia, or just really hypotensive to cause something mimicking heart block. So these are not common culprits. And increased vagal tone. In some young patients, they can present with syncope, and we sometimes do cardiac monitoring, and we find that they can have vasovagal syncope with intermittent complete heart block. And that's an interesting decision to make what to do with those patients, because these are young patients. We think these are vasovagal. And in selected patients, sometimes we will put pacemakers in, but those are very, very selected cases. So this is first degree AV block. You can see this heart rate is 56. If I measure it, I measured it out, it's about 324 millisecond. QRS is 96. It's a routine ECG. Patient had no symptoms, so we do nothing about it. Again, there is another patient. This one is markedly prolonged PR interval. If you look at it, it's basically from here, it's 800 millisecond, almost 880 millisecond PR interval. Again, if the patient is asymptomatic, there is nothing to be done for this. But where is this block? You know, we talked about this PR interval. It involves conduction through the AV node, his bundle branch. What is this block? If you look at it, again, I'm going to bring this picture up. This is the area where the PR interval conduction is going on. So this is the patient with first-degree AV block with PR interval of 320 milliseconds, and patient had an intracardiac EKG done, his bundle. If you look at this, AH is prolonged. Markedly prolonged HV is good. And this is a patient where if I give atropine, it may get shorter. If the patient exercises, it may get shorter because AV node is affected by the vagal tone. So this is another patient whereby the PR interval is 230 milliseconds. If you look at it, the HV interval is prolonged. This is a patient where if I give atropine, actually I can make it worse, because what the atropine will do, atropine will increase the sinus rate, will worsen the HV conduction because of high rate. And that's why you have to be careful who we give atropine in case of heart block. First-degree AV block, mostly asymptomatic. Now, marked first-degree can rarely cause symptoms, but this is very interesting. I saw only one patient whereby one physician decided to put a pacemaker in for first-degree block, and I kind of critical, but I looked at why he did it. So let's look at this patient. This patient, heart rate 80, PR interval is about 840 milliseconds. If this patient's heart rate goes up, like here, you can see that the R to P, so this QRS and next P wave is very close. As the rate goes, it goes closer. If it were much farther and if the P and QRS became together, then the atrium will contract at the time of the ventricle contracting, and patient may develop symptoms like pacemaker syndrome. And the patient that got the pacemaker, I actually talked to her. She had this pacemaker done about 15 years ago. She was very, very symptomatic. And once the pacemaker was put in, it became symptom-free. But that's one case that I've seen somebody run a pacemaker for first-degree AV block, and justifiably so. But these are outside of our clinical recommendation. And this decision should be made very, very carefully if we want to treat this first-degree AV block with pacemaker. How about this one? So this is, we can see that there is P, QRS, prolonged, and then this is blocked. And then the next PR interval is short. I think this is what we look at normally. The last conducted PR should be longer than first conducted PR interval after the block. And if this is shorter, this is most likely Wenckebach AV block. So this is how we look at it. Here, P2R is 240, 310 blocks, and then back to 20. So this is classic Wenckebach. Again, the PR gets longer, PR gets longer, and then blocks. So where is the block? So this is a case where you can see that there is PR longer, and then there is a P wave which blocks. Where is the block in this case? If we look at the intracardiac, this is A to H 240 millisecond, A to H 535. There is A, but there is no his. That means this block happened at the level of AV node. And this patient, if I give this patient atropine at this point, it will improve because AV node has is supplied with the vagus nerve and conduction can improve. I'm not that I'm saying this Wenckebach needs AV node. Wenckebach block needs treatment, but it will improve. Also, if this patient exercises, the PR interval would get better. But look at this one, another patient with first-degree AV block, PR little longer, and then there is a blocked PR. This patient is a little different. This is A to H, and there is double his, and there is a prolongation of H2. So this patient has infra-his Wenckebach block. This patient, if I give atropine, it will make it worse. So this is infra-his, and you can see that the last A, H, and there is a block. That means this split is blocked. So the conduction block was in the AV node. Now, how about this one? So this ECG, suddenly, if I look at it, it may look like sinus bradycardia, but you can clearly see that there is a P wave here, P wave here. And so PR, no conduction, so 2 to 1 AV block. And I just, for the sake of everybody understanding, I've marked the P waves. RR interval is 1280, 1320, and the P2P is 660, 620, close to 1320. So it's 2 to 1 AV block. And there is some variation because you need to understand that P2P interval is not always constant. So here there is a little difference, 660, 660, 620, 660, 660. So there is a variation in the P. So this clearly 2 to 1 and most likely type 2, Mobius type 2 second AV block. And why I'm saying that, number one, this patient has 2 to 1 block. Second, there is bundle branch block, right bundle branch block with left anterior fascicular block. Most of these patients are prone to Mobius type 2. Now, this is a case where I have 2 to 1 AV block. Question is it type 1 or type 2? Sometimes it can become confusing unless we have a long rhythm strips. Here I have a regular ECG of this patient at a defined time. Patient has first degree AV block with right bundle branch block, left anterior fascicular block. And then here you can see that there is PR prolongation. Block first conducted is short. So basically, this is Voinkeba type, which goes into 2 to 1. And so the block is suprahis. And if this kind of patient comes and a patient is markedly bradycardic, if I give atropine, it will improve. Whether this patient needs treatment with pacemaker or not, that's a different decision. Because where suprahis AV block doesn't mean that they may not need a pacemaker. Infrahis AV block with 2 to 1, all of them will end up needing pacemaker. And in suprahis 2 to 1 AV block, some of them, depending on how symptomatic they are. Sometimes I'll put this patient on a treadmill. And if I find treadmill exercise with low exercise goes into persistent 2 to 1 AV block, patient has symptom of shortness of breath, I may want to give a pacemaker to that patient. How about this patient? So this patient, again, it's a little bit prolonged PR with 2 to 1 conduction. And then if you look at this ECG, there is actually Voinkeba pattern. See, PR short, longer, and blocked. So that patient is actually 2 to 1 AV block. At this point, if somebody, I'll diagnose it as 2 to 1 heart block. Somebody says, is it type 1 or type 2? Is it at the AV node or his bundle level? I can't tell that from this. But most of the time, there is general theory is, if the PR interval is long during 2 to 1, it's most likely AV node level block. If PR interval is short, it's at his bundle level. Here is one patient. If you look at it, 2 to 1 heart block, you can see P wave, not conducted, conducted P wave, not conducted. And the baseline PR is not too long. It's about 200 milliseconds. Same patient. Here you can see that P QRS, there is no prolongation then. This is this classic Mobius type 2 and patient has baseline. Interesting block because look at this. This bit has left bundle and this bit has right bundle. These are the patients that worries me a lot because they have both right and left bundles. One conducted QRS as left bundle, one conducted as right bundle. You have to be careful with these patients. If this patient comes to me with history of syncope and no other reversible cause, I would put a permanent pacemaker in the same day. We try to avoid putting temporary pacemakers. But you have to be careful with this kind of patient because they have block of both bundles, left bundle and right bundle. So how about this one? This patient, clearly you can see QRS complexes. If I look here, it looks like sinus bleeding, but look carefully, the PR interval is changing. But the RR interval is constant. If anybody has doubt, I have a long rhythm strip here, whereby you can see that QRS complexes are same interval, P is changing. And if I put the P, you can see the P waves here. Now, this patient, one interesting thing about this patient is that this patient has narrow QRS complex. So if this patient comes to me in the hospital with history of shortness of breath, and I find this ECG, there is no need to put a temporary pacemaker in this patient. You can admit the patient, just make sure there is no other cause for this heart block, put a permanent pacemaker in. So there are people who are very, very nervous about putting a permanent pacemaker, that when I'm putting the leads in, will the patient go into heart block? There is a possibility, but less likely because this patient doesn't have a right or left bundle when block. So if you put a lead just straight away without temporary, no problem at all. I worry about cases where they come with complete heart block with left bundle morphology pattern, because if I knock out the right bundle, then I can produce complete heart block. Otherwise, this patient just can go for a permanent pacemaker implantation. So this is another patient. You can see that this is again complete heart block because there is clearly AV dissociation in these leads, and it is a right bundle. Not really left interface, a right bundle, typical right bundle pattern. This should not worry me much. This patient, of course, is 90, but her baseline ECG was left bundle. So the escape rhythm is right bundle. Her ECG next day was left bundle. That's where I will rush into doing pacemaker. Again, I will not put we try not to put a temporary pacemaker, but if you do so, I won't, blame you. So I'm going to, I think that's pretty good. I wanted to keep it short lecture today, 20-minute lecture, and then I have to kind of funny ECGs. If you have any question, I will answer.
Sir, can I ask you a question?
Sure.
Sometimes we find patient regarding the first degree heart block, PR interval more than 320 milliseconds,
Yes.
and
Yes.
patient comes effort intolerance with a effort intolerance. What am I going
Yes.
to do about that?
So that's the question that I'm going to, now effort intolerance, there are many definitions. Somebody 60, 70-year-old in Bangladesh or even in this country doesn't exercise at all. Of course, they will have effort intolerance, but I will put those patients on treadmill, a supervised treadmill. That means if I'm going to do the treadmill, I'm not just going to order a test. I'm going to talk to the technicians, or I will be there to see how the patient is doing. Two things can happen. One, they can develop this pacemaker-like syndrome, or during exercise, they can develop 2-to-1 heart block. And selected cases, yes, a pacemaker should be considered, but
I think,
yeah.
sir, I think exercise stress test is very important, this type of situation, in particular situation when people have certain type of AV block. Particularly, as you mentioned, Dr. Wadud mentioned that when you effort intolerance and prolonged, PR interval, definitely if they're symptomatic, then they might benefit with that because of the pacemaker-induced syndrome that we call it. But the second important, thing that we need to remember that when the patient has twist-to-one block, treadmill stress test is extremely important, because if this like a twist-to-one block improves, goes away with exercise, that means his bundle is still intact. He has AV nodal block, and with sympathetic activity, it's improving. On the other hand, with exercise stress test, if you just do and his block gets prolonged and more advanced, then it's beneficial. That then you can make the decision of putting a pacemaker. So we really like to focus on in this type of situation, really do a supervised stress test, that you monitor. That is very important sometimes in clinical decision making.
Sure. Any other question?
Sir, I have a question, sir.
Sure.
Sir, sometimes we are getting some patients that is at the age of 16 or 17 years, young patients, complete heart block, incidental diagnosis, denies any kinds of the symptoms. There is no history of the fever like this, sir, and heart rate is 40, 42 like this. So, sir, how will you label this patient? Usually we recognize them as the congenital heart block. We label it like this. And what type of investigation? Sometimes there are, that is the cardiac MRI is almost routinely done. Sir, how will you actually manage these kinds of the patients, sir? That is totally asymptomatic.
Yes. So, I mean, as I mentioned before, in countries like developed countries, children will have EKG done when they're born. In Bangladesh, they are not. So somebody comes 14-year-old, complete heart block, narrow QRS. And my first assumption will be congenital complete heart block, unless I can prove something else. Now, expensive investigations are good, but it has to be focused based on what? I do an echo. Is there any reason to believe patient has sarcoidosis? And those are the kind of things. Like just doing, I mean, MRI, we'll do it, MRI, if I think that there is a possibility of sarcoidosis. And the treatment-wise, what we do with these patients, they are doing well. We keep following them, and we'll do echo.
আমি কথা বলবো না একটু পরে কল করবো না
Ashok, if you could mute yourself.
Ashok, please mute.
Okay. So what we do, we keep following these patients for symptom and also cardiac size. If I find at any point there is a big difference between atrial and the ventricular rate, like atrial rate is 120, ventricular rate is 40, patient is having cardiomegaly, I think that is a point at when you have to make a decision regarding pacing. And the reason I'm trying to delay the pacing, even the best lead that we have today will have a certain lifespan. And so you want to minimize the number of leads that this patient is going to need.
Thank you, sir.
I have one question here.
on questions are here regarding cardiomegaly. Sometimes we see that there is no cardiomegaly on chest X-ray, but echo shows there is some LA enlargement. This patient subsequently has prone to develop chronic atrial fibrillation.
With congenital heart block?
Yes, sir.
Well, the cardio.
So if this patient develop chronic atrial fibrillation, this will be very much difficult.
Sure, but I don't think there is any data to prove that correlation. It's not unless you have something that you have seen. I don't think there is any systematic data on that issue. When we talk about cardiomegaly, of course, it will have to be by echo. And the cardiomegaly will be, we are looking at the left ventricle.
But now how the guidelines says, sir? Guidelines, I think they are very much liberal to put the pacemaker irrespective of age, if it is more than 50 and the child has reached the
I mean, you're talking about 50 for a young person is pretty big. You may choose to. I mean, am I going to do that in Bangladesh if I am practice? Somebody who comes from the village and you are, they'll have to sell all their land just to prevent AFib. I'm not sure about it. But yes,
Thank you,
this is something that we need to keep in mind.
Thank you, sir.
Sir, if in congenital heart block, should I roll up treadmill to see the maximum heart rate? It is in.
The question is, do I need to access? So maximum heart rate, I always bring up this issue. The heart rate, what is the value of the heart rate? An elephant has a heart rate of 25, leading a pretty better life than we do. A blue whale has a heart rate of 8. It depends on the symptoms. So if the patient is not symptomatic, if a young boy can run around, do things without getting shortness of breath, what is the point of doing a treadmill stress test on that person? Normally, we don't.
So these are the common some hospital admissions. Sir. That is the some of the patients comes with complete heart block with history of the beta blocker. After admission, we stop the beta blocker and calcium channel blocker. After 24 or 48 hours, the rate becomes sinus. Then we discharge the. So what kind of advice should we give these kinds of the patients, sir?
Yeah, I mean, this is a debate. If you look at the AV node, the sympathetic effect is not great. So beta blocker causing heart block in these patients probably is unmasking. And if you longitudinally follow this patient, you probably end up finding that a lot of these patients will develop heart block in future, especially if they have bundle branch block. That's the current consensus. It's not that we routinely put it in. Majority of the time, if somebody comes with complete heart block or 2-to-1 heart block with bundle branch block, you will find that even if you stop the beta blocker, but nothing happens to the conduction. They stay in complete heart block, they stay in 2-to-1 heart block. I mean, it's a consideration. Any questions, other questions?
Sir, sometimes we find patient who comes, they have both LBB pattern on the limb leads and RBB pattern on the chest leads, and the PR interval is borderline, let's say around 200 milliseconds. And they have a complaint of dizziness, but no history of syncope. And extended halter, like 72 hours halter, do not show any severe bradycardia or complete heart block. What are we going to do about it when we do not have other modalities like doing, we cannot do the follow-up for a long period over 7 days or something like that? What are we going to do about that?
Okay. Dizziness. Dizziness is such a vague symptom that I never promise anybody anything. It can be from many, many causes. If this patient came with syncope and then bundle branch block, that's a different story. So what we do, let's say somebody has bundle branch block, left bundle, right bundle, depending on the patient's suspicion. Sometimes with left bundle, if we think it's a true syncope, somebody 86-year-old, we tell them, look, we can do two things. One, I can put a pacemaker in you. Second, I can do a EP study to look at the HV interval. Third, I can put a loop recorder in. And that will be the patients with syncope, not with dizziness. I'll just follow them clinically. Anything else?
Sir, we have got many of the patients that is the patient resting ECG is RBB. Patient has got history of 1 or 2 episodes of syncope or pre-syncope. Other tests are normal, so that is echo, halter, everything is normal. Should we do these patients that is diagnostic EPS, sir?
Yeah, I mean, listen, diagnostic EP is a fantastic modality, putting one catheter in the his bundle region. And you can look at the intracardiac conduction intervals. And then if they have recurrent syncope with bundle branch block, we routinely put loop recorders in these patients.
Sir, can I have one question, sir?
Yes, sure.
I have a patient referred to me. I don't know why the halter was done. It was complete heart block during sleep. I don't know why the halter was advised, but there is no symptom. And during sleep, there's a complete heart block. Patient doesn't have any complaint. Patient in following last 3 years, I don't put any pacemaker. Should I continue like this or like?
Yeah. So, I mean, when I was discussing the autonomic tone, that one of the etiology of heart block is vagal tone. And it can happen under different circumstances. If somebody has vasovagal syncope, they can have high vagal tone causing heart block. Nighttime, the vagal tone goes up. And we don't put pacemakers in those patients. Even if this patient has syncope, I would put a loop. Let's say somebody is 35-year-old, 40-year-old, have syncope, develops nighttime intermittent complete heart block. Before I put a pacemaker in, I will have to have correlation between the symptom and the heart block. And I'll give an example of case. This is a female that I'm following now. Somebody else put a permanent pacemaker in. 42-year-old female, morbidly obese. She had syncope. And she had a heart monitor which showed intermittent complete heart block. And justifiably, physician put a permanent pacemaker in. Guess what the follow-up is? Patient had 6 episodes of syncope after pacemaker implantation. So I'm just giving an example. It's an anecdote, but this young female got a pacemaker. Probably her syncope is totally unrelated. Maybe she has vasovagal syncope, but her syncope didn't improve at all. So your patient, I will not put a pacemaker in.
Sir, one more question, sir.
Is there any if the sleeping heart rate in complete heart block that Dr. Mohsin was telling, heart rate is below 40,
No,
sleep with complete heart block?
No, during sleep, there is a complete heart block.
But what is the junctional rhythm or escape rhythm that happens during
Rhythm
sleep?
this is the junction, not QRS complex wide, narrow.
So what was the rate at sleep? If it is very low with 35 or 36 or even 30, does it justify in a different way, sir?
I have seen patients with pause of 15 seconds,
Sir.
and we have not put pacemakers in. So, but that's we sit down, we talk to the patients. We just don't look at the Holter. We see the patient, we talk to the patient, and then explain to them what it is. I mean, you're talking about heart rate of 28. I'm talking about SST of 10 to 15 seconds.
Yes, sir.
We didn't put pacemakers in.
So regarding age, any difference between age?
Yes,
asymptomatic patient with prolonged pause in younger age and elder age, which one is more prone to develop symptom and subsequent incidence of something, and which one is more indicated, younger age or older age?
Yeah, the question is, the younger the person is, I have higher threshold of putting a pacemaker in. So let's say somebody 85-year-old comes to me and has some bundle branch block. That's one patient. My threshold of pacemaker will be lower. I'll have to justify it. But a young person, 40-year-old, I'll have a higher threshold of putting a pacemaker in. And that's where it comes. I mean, I sit down with patients, I get detailed history of their syncopal episode. What is the circumstance? Why they're standing down, sitting down? Where they're lying at the time of syncope? So if you see my note, you'll see a detailed description of at least 1 or 2 episodes of syncope. Of course, now with the availability of loop recorder, life has become easier because I can put a loop recorder in next time they have a syncope and rhythm was normal. So nothing to do with the heart rhythm. Rhythm showed bradycardia, significant bradycardia or pause, of course, get a pacemaker. So that made our life very easy.
Sir, can I ask one question? I'm Dr. Aziz from UK. So you said you have not put pacemaker for a patient with 6-second pause. And you deal with the patient. So what is the reason, sir? What is the thing behind your mind?
Okay. A young person comes in with syncope. It can be vasovagal syncope. And I do a Holter and find a nighttime pause. I'm not talking about daytime pause. Even when I find daytime pause, what I do, I talk to the patient. Like the other day I saw a patient, a pause of 6 seconds at 9:30 in the morning. Patient had no symptom. Loop recorder was put in for paroxysmal atrial fibrillation. So I talked to the patient. I said, what time do you go to bed? 1 o'clock in the morning. What time do you wake up? 10 o'clock in the morning. So that patient had the pause during sleep. But if I took normal convention, I would say, well, the patient is daytime, it must be symptomatic pause. And that is the reverse is true also. I had a patient with loop recorder, 5 o'clock in the morning, had a 9 or 10-second pause. And my initial instinct was to ignore it. I called the patient. Guess what? She works at night. And at 5 o'clock during work, she went to the bathroom and passed out. So these are 2 different scenarios of putting pacemaker. So if I did not call this patient or if I did not talk to the patient, that when she sleeps, I would have probably ignored that. So that's why the clinical history becomes so important.
Sir, I can present one more question, sir.
Sure.
Sir, one of my very close patient, that is a 60-year-old male, diabetic, hypertensive, has got mild coronary disease, normal LV function. This patient was presented in emergency just two weeks back with the severe vertigo and 1 episode of pre-syncope. There is no syncope. The patient was admitted in the hospital. Temporary pacemaker was not put in. At the time, the patient was taking the beta blocker along with the other antihypertensive medication. The beta blocker was stopped. Then the heart rate becomes normal the next day, that is around 60. But after a few days, I did the diagnostic EPA study. At the study, that is the SNRT was 600 and ASB interval was 65. I have not put the pacemaker. The patient is actually, I wanted to discuss it with you, sir. There is no more symptoms. Sir. The patient is okay now. I have not given the beta blocker anymore.
Yeah. So what we do, anybody with HV interval of 100 with syncope, or even without syncope, with conduction disease, they get pacemakers. Between 70 and 100, anything over 70 with syncope, we consider pacemaker with bundle branch block. But in your case, I think that is a good decision. HB is 55 milliseconds. That's the longest you could get. And you just follow this patient. And remember that 80% of patients never had a second syncope in real practice.
Thank you, sir. Any more question from the forum?
I want to show two interesting ECGs for everybody.
Okay, sir.
So I think we still have a little time. So if we could put up some question. Paul.
মনে হয় ভালো হয়েছে স্যার। কামরুল পোল দিও কিন্তু।
Was the poll given?
কামরুল পোলটা
দিচ্ছি স্যার।
No poll yet, right?
Not yet, sir.
Kamrul, any?
Okay.
Ah,
Okay, good.
D.
I want a few more answers.
From the audience, we want more response.
Yeah, I think response is pretty good. So far, we have 14 responses. Listen, answer the question. Don't worry about being correct or wrong.
I think so. Sinus body consistent dextrocardia.
Yes. So let's see. So in the poll, we got few answers. One was A. So in multiple choice question, there are some tricks. One of the trick is this patient bradycardic or not? So this patient heart rate is 56. That excludes one totally because it's not sinus bradycardia, because I have mentioned sinus bradycardia other places. So that's one of the trick that you should use in answering question. So the question is between C and number 3 and number 4. The leads were correctly placed in this patient because we verified it, and that is negative in, it looks like arm lead reversal, but it is not. So, and then chest leads shows ROA progression poor. So it's number 4 is the correct answer. And so what we did then, I changed the leads completely, including reversal of the arm leads. So the chest lead, we put it on the right side. Arm lead, I reversed. Look at this. This looks perfectly normal when you reverse it. And when you reverse it, you have to mention it so that people understand. Now, look at the chest X-ray of this. It's dextrocardia. So I have another patient, similar ECG. So we thought dextrocardia. We corrected the chest lead, but not the arm lead. Look at how it looks. And the chest X-ray, dextrocardia. Now I have a question. What is the difference between these two chest X-rays? Two different patients, but anybody, any comment on these two X-rays?
The gas shadow, stomach gas shadow. On the right side, it's on the left side. So there's
yes,
situs inversus.
And the diaphragm. This
and
one, right side elevated, this is left side. So this is total reversal of all the organs. And this is different. So I think this is, please remember this. I thought that it'll be interesting to show this to you. See, I got this one, I got long time ago. This just I got recently. So I thought I'll put both of them together. Thank you.
Thank you, sir.
So any more questions from the forum? So is there Hafiz bhai? Dr. Hafiz? So,
I'm still here.
yes. So,
It was nice session, definitely.
so Aziz bhai, I will request you to comment on the lecture and conclude the session, today's session.
All right, I'm not actually, it's an honor for me to say something about Rafique bhai. First of all, he's an excellent teacher. Okay, there's no question on that. I enjoyed it firsthand. He was my attending when I was doing my residency. The second thing is that very simple thing, but very, very important point he made. That's extremely important to remember that because reason is it's a logical thinking in managing AV blocks. So you have to keep in mind, always think about logically. Second, symptoms that he clearly again and again mentioned that whether the patient is symptomatic or not. Okay, and also look at certain things that certain quick tests we can do, like stress test, just putting on a treadmill and supervise yourself, not that nurse practitioner or your assistant is doing, is whether symptomatic or not on the treadmill to make some decision. Because sometimes we can put early and in unnecessarily pacemaker, the patient is going to have it lifelong. Maybe if we put it in younger age, they will have change in 10 years about 2 or 3 times in their lifetime. And risk of infection is significant, of pacemaker, infection. So we have to balance those very carefully, and definitely some patients will need it. We have to do it. So this lecture kind of formulated together in a very concise form, and let us think about that twice when you put a pacemaker. But that's very interesting lecture. I enjoyed it myself.
Uday Shankar আছে Uday Shankar. Hello Uday Shankar, unmute yourself. So thank you, sir. Wadud bhai. Hello. Professor Abdul Chowdhury.
Sorry, I was indisposed. Atahar bhai.
Yeah, yes. Just wrap up the session and conclude it, please.
Hello.
হ্যাঁ Wadud bhai.
কিছু বলছিলেন?
না বলছিলাম যে সেশনটা কনক্লুড করেন। আমাদের নেক্সট সেশন হবে হচ্ছে নভেম্বরের 10 তারিখে। সেই দিন আমাদের গোবিন্দ ময়মনসিংহের প্রফেসর গোবিন্দ সেই প্রেজেন্টেশনটা করবে। আর তারপরে লেকচারটা মানে আমি স্যারকে রিকোয়েস্ট করব। আর আজকের সেশনে আমাদের রফিক স্যারের যে প্রেজেন্টেশনটা হলো সেটা আমার মনে হয় যে উই এভরিবডি এনজয়েড ইট। স্যারের লেকচারে নট অনলি দ্য কনসেপ্টস অ্যান্ড নলেজ, we always learn many things, that is the art of presentation, simplification, how to prepare the slides, many things. There are actually, we are a long time learner from sir's lecture. Excellent lecture, sir. Thank you very much. And now I would like to conclude the session, and thanks everybody for participation. Thank you, sir.
Thank you.
Thank you.
Thank you.
গুরু বলছিলাম তো এই জন্যই।
Thank you. Thank you,
Thank you,
sir.
sir.
Bye.
Thank you, sir.
Assalamu alaikum.
Thank you, sir.
Okay.